material in there. Okay, we want to make sure that the patient has been prepped properly, because if there's any residual material in there, it'll show us as some kind of anomaly or some kind of neoplastic process. Okay, so it's good to have a before, during, and after shot. So the scout is to make sure that the patient has been cleansed properly. Does it happen sometimes where you take the scout and there is stuff in there? Yes, and we have to send them home. Sorry, we can't do it. We got to try again the next day. Okay, so it has happened. Room preparation, again, make sure that your floral unit is working, footboard in place. You're going to take your bucky and slide it all the way down, because we don't want the bucky in the middle of the table, because when the x-ray shows up, you're getting hit with all that scattered radiation coming from this area right here. You guys remember the x-ray for floor is underneath, right? Okay. The table is going to be horizontal to begin with. They may stand it up. So what that means is make sure that the padding is also tacked down with some tape. Okay. The two guys who saw BEs, did they stand the table up? No? No? Okay. All right. So they may do it on certain occasions. They don't do it all the time, but it's better to be ready than not. Okay. So again, I highly suggest is just tape down the pad up here and down here. It also helps when you tape it down, top, middle, bottom, because during a barium enema, the patient is in all different directions, literally. Literally. It's not like the upper GI where you just have them move around so and so. In the barium enema, they're completely moving around in all different directions. So what that means is while they're moving around, they can pull out the sheet from it. They can untuck the sheet and it starts unraveling and it starts wrapping around their legs. Okay? So if you tack that down, you won't have that issue. Let's see here. KY jelly. What's that for?
Depends.
KY jelly, what is it for? Ooh, baby. Yeah, you want to be nice to your patient.
What if you don't want to be nice?
You don't want to be nice to you want to be nice to your patient. Okay? So you're going to use KY jelly. They also have lidocaine jelly for those patients who have hemorrhoids. Okay? So we can numb it up a little bit before we put this in. Okay? Hemostats for your different tubing. So this is a hemostat. Okay, you guys know this is a hemostat, right? Hemostats, here's a large one. Inflator devices, more inflating devices. So inflatable cuff, air cuff, an IV pole, a bedpan, just in case, a trash can nearby. Again, this is for, that'll be used at the end of the procedure. Contrast media. We are going to be using a little bit thicker than what is used for an upper GI. It's thick barium, but not thick barium that you would think is the pasty type that they would use for swallow studies. It's just a little bit more thicker and dense than an upper GI version. Okay? So remember the barium that you sampled last week? That is for an upper GI. So for barium enema, it's just slightly more dense. Towels and linen, again, just be ready. Glucagon injection or lidocaine in the barium. What is that for? Okay. When you're getting something like that pumped into your bowels, well, naturally your bowels are going to want to contract. So if they over-contract, glucagon will help relax the bowels. It minimizes it or helps it relax. And so lidocaine also in the barium will also help that to minimize any type of contractions. Again, those are rare occasions. It doesn't happen regularly. So be ready to have glucagon. And who's going to administer that glucagon injection? Not you. Who? The doctor. The doctor or the nurse. Okay. who's ever in the room, the doctor or the nurse, but it won't be the technologist. It's not within our scope of practice. All right? The contrast media for the barium enema, single use, yeah. Single system just means this. This is a single system, closed system. Single use closed system. So this is a closed system. Okay? An open system is this. And I don't know anybody who does this, but it's a bucket. Okay? And then you have a nozzle here, a nipple that you hook up the tube to, and you just pour the contrast in there. It's an open system, closed system. So that's the difference between the two. Things to consider. You probably want it at room temperature because, again, if the contrast was cold inside the bowel, you can induce contractions, and it's very uncomfortable. So when you watch your technologist prepare the barium comes in powdery form. Okay, so powdery form. So if you're going to add water to it, use lukewarm water. The jug that I passed around, that's already pre-mixed. Okay, so they come in unmixed form, they also already come in pre-mixed form. The one that I passed out was pre-mixed. So that, you don't keep it in the fridge, it should be in room temperature. So that will be more appropriate, more comfortable for the patient. So we want it as close to the room temperature as much as possible. But before you start flowing that contrast into the patient's body, okay, and let's just say you pre-made it, pre-mixed it, and it's been a while before you start doing the barium enema, just make sure to shake it again because it's a metal suspension, it'll settle to the bottom. So make sure you mix it again before you start flowing the contrast into their bowels, okay? All right, glucagon, in case we have some contractions, topical anesthetic, we were talking about the Lido jelly in case. This one I've added too. Verify that they don't have a latex allergy. This is made out of latex. Okay, this is made out of latex. And so if you put this inside the patient's body and they have sensitivity to latex, they may have an allergic reaction, but worst case scenario, they can have an anaphylactic response. That's a major response. Okay? And some of you guys too, do you guys know if you have latex allergies? You do, okay? So in that case, you gotta wear special gloves, right?
Yeah.
Okay, powderless, non-latex gloves. And so they have a lot of products out there now which is non-latex, which is good. The gloves that we have that we're going to be using in venipuncture, they're non-latex. I forgot the name, it's like Neo something. Nitrile, that's it, nitrile, yeah, nitrile gloves. But if the patient has a latex allergy, be careful, okay? Even the powder from that, if you inhale it, if that patient inhales it, okay, it can cause problems. All right, any questions here? Okay, the different types of tips. This one here is going to be most common that you will see in CT because they don't use very, very thick barium. They use thin barium because the sensors of CT is a lot more better than that of X-ray, so they get better imaging with less dense type contrast, or they use gastrograph. So this is more used for a liquidy type of contrast media. The ones that you'll be seeing in radiology looks just like what I have up there. It's a retention tip. It's called retention because of the balloon. Okay, so when we inflate that, it prevents the tip from being pushed out. But you'll notice that there is a difference between the two here, in that this one attaches to the barium bag, and this one is what's going to inflate the balloon. Okay? Whereas over here we have an extra line that will allow us to pump air into the colon. So that air is coming out of the So the air is coming out of the holes at the tip of the enema. Okay. And it's so cool because when you start pumping air into the colon, you can actually see the colon go whoop, 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 whoop. And then you hear the patient going, it hurts. Okay. So yeah, so here we have the extra port for air to be pumped in. This one doesn't have one. All right, so barium enema preparation. What are we gonna do here? We're gonna get them on their left side. This is the Sims position. So they're laying on their side, one leg over the other. So it's the right leg that's gonna go over their left leg. Now, before we get started, are we gonna inform the patient what we're doing? Okay. No surprises. Pull up on your side and then, oops, okay. Let them know what you're going to do. Okay?
Unless they like
so
surprise.
Explain what you're going to do. Miss Jones, I'm going to be inserting an enema tip here in just a second. Okay? Now you're going to feel uncomfortable. So I'm now explaining the procedure. You're going to feel uncomfortable during the procedure. We're going to try to do our very best to get through this procedure as quick as we can. Once we get that tip in you, do your very best not to push or bear down. Try to relax. Okay? Relax your abdominal muscles. So these are instructions that I'm going to give them. Relax your abdominal muscles. Concentrate on your breathing. Because the relaxation of your abdominal muscles and the concentration of your breathing will minimize any type of discomfort as well as contractions that occur during the procedure. Now, naturally, what's going to happen is when you put that tip in, there are sensory muscles around the anus that forces you to have a contraction. Okay? So naturally, what they're going to want to do is they're going to want to bear down. So you got to remind them not to bear down. Now think again, now you're opening up that balloon, pumping up the balloon. Now they're going to have the urge to go even more. Again, remind them not to bear down. Okay? So communicate with your patient. Wear gloves. Okay? Don't go commando. Okay? Drain air from the enema tubing. What that means is you're going to want to purge the contents. You want to fill up the tubing as much as possible before you put the enema tip in. So prior to you putting this tip in, you're going to fill up this tubing. Can you guys see okay? Can you guys see back there? Watch what's happening when I lower or go up with the tip. You can see that when I put it near the level of the bag, it fills up to the level of the bag. You see that? Can you guys all see that back there? See what I'm doing? Here's the fluid right there, and I want to fill up this tube here with the contrast, and so I just put it at the level of the bag until it fills up right there, and then I'm going to clamp it. Okay, I'm getting rid of the air, so just put it at the level of the bag. Do you guys see that, or
Sure.
no? Yeah, you guys, okay. Okay. And then once that happens, once you get at the level, then you just clamp it. So now the contrast can't go anywhere. See what happens? It stays in the same spot no matter what level I put it in. Okay? So get rid of the air. You still want to have a little space, a little gap there. Okay? You don't want to put the contrast all the way to the tip because even if it's clamped, even with gravity, we don't want contrast seeping into the colon until the procedure starts with the doctor. Okay? All right, so drain air from the enema tips. Again, we want to fill up the line, the tubing, with contrast media, and then we're going to lubricate the enema tip. So here's a summary of tip insertion. So you've explained what you're going to do. Ms. Jones, in a moment here, I'm going to insert the tip. It's gonna feel uncomfortable, but I want you to do your very best not to bear down, okay? So describe the tip insertion procedure to the patient, answer any questions that they may have. Place the patient in a Sims position on their left side, right leg over the left. Shake in a bag once more to ensure proper mixing of the barium is done. Allow barium to flow through the tubing. You want to fill up the tubing, but not all the way to the tip. Again, you want to leave some space, some air space, because we don't want any barium leaking into the patient before we start the procedure. Wear gloves. Coat the enema tip with water-soluble lubricant, and wrap the proximal aspect of the tip in a paper towel. What that means is we're not going to get the tube and lubricate it freestyle. You know, what you're going to do is you're going to get the tube of lube, put it on a paper towel, and you just, okay, that's how you get it prepared. Okay? Okay, so wear gloves, coat enema tip well with water-soluble lubricant, wrap proximal aspect of enema tip with towel. Okay, so that's how you lube it up. Number 5. All right, Miss Jones, I'm going to go ahead and insert this tip now. Are you ready? Okay, are you ready? You see, take a deep breath in, blow it out, take another deep breath in, and as they're exhaling on the second one, now you put it in on the exhale, okay? Because on the exhale, they are more relaxed. They're not so tense or tight in the bottom. On the exhale, it will allow for better insertion, okay? So on expiration, direct the enema tip towards the umbilicus, that's towards the belly. I'll show you guys here the pictures in a minute. So you're gonna go in towards the belly, the umbilicus, and then you're gonna angle up and go all the way. You're only going to go about 3 to 4 centimeters. Okay? Do not force the enema tip because now you're going to be hitting rectal wall and you can perforate it. So if you feel any resistance, stop, reposition, and then reinsert again. If you continue to have resistance, stop what you're doing. Okay? And call the doctor or call the nurse. Okay? You may have to tape the tubing in place, so you may have to wrap it up with some tape and tape it up against the butt cheeks. You usually don't have to because the inflation of the balloon is just enough. But you may have older patients who don't have that rectal muscle. Okay? So you may have to inflate it twice. So once you inflate it, okay, let's just say we inflated the balloon. Again, this is not working. Once you inflate the balloon, okay, it's inside. Once you inflate the balloon, you're going to give it just a soft tug. Okay? If there's no movement, then you're good. But if you tug on it and it comes right out, okay, what you might have to do is you may have to double inflate it. You will see your techs double inflating sometimes with geriatric patients. So now the balloon is this big inside the rectum, which is okay because the rectum, again, it's a cavity. It's a cavity. So the inflation, you're not inflating the balloon on their. You're not inflating the balloon in their anal sphincter. You're inflating the balloon inside the rectum. So if you double inflate it, it's okay. You understand? The balloon will be in here.
So when you say double inflated, you mean just inflated more?
Yeah, so what you're going to do is you're going to give it one puff. So you would give it one puff. Okay.
That's considered regular inflation?
This is one inflation. Okay. Then you're going to clamp that so the air doesn't go back into the bag. Okay. Reconnect it and then give it one more pump.
Okay.
Double inflation. Okay, and then you may have to tape it up on their bottom.
Can we do triple inflation?
I've never seen triple inflation. Never. Okay.
No way.
All right. So proper way of doing this. So let's go back over here. make sure I can tape it. Ensure IV pole enema bag. Okay, make sure that the IV pole enema bag is no higher than 24 inches above the table. Anything more than, remember, it's the delivery of the contrast is on gravity. So the higher that you have the bag, the stronger the force of the contrast going in. Which, if it's too high of a pressure, higher than 24 inches, you can cause perforation in the bowels because it's just shooting up there so rapidly and quickly. Okay, so no more than 24 inches. Okay, all right. Any questions? So proper enema tip insertion is that you're going to make your way towards the umbilicus, the belly button. Okay, so tip in, and then you're going to change your angle to go superior, and then go the rest of the way up. Well, how do you know if you're in the right place? Well, if you're not sure if you're in the right place, when you inflate the balloon, it will pull the enema tip further in. Okay, it naturally is going to pull the enema tip further in when you inflate the balloon. Okay, and now you know you're in a secure place. Okay, so again, up there, instruct the patient, push, relax, concentrate on the breathing. So, let's go back over here. So when inserting the tip, okay, when you insert the tip, don't do it like this, okay? Because if something happens, you want to go over here, okay? You're going to rest your arm on their hip, okay? See this hand? This is what I'm going to use to pick up the butt cheek. And now I'm going to look and insert the tip, okay, towards the umbilicus and then superior. And then I'm going to inflate the balloon, okay? But again, you don't want to do it here. Word of caution. If you have an obese patient, you're going to get some extra flap in there, okay? So there'll be some extra folds. So make sure that you're moving those extra folds away so you can see where you're putting in that tip. Sounds funny, right?
Mm-hmm. Funny for whom?
Yeah. So, again, years and years ago, one of my patients that the doctor ordered a barium enema on was on a 19-year-old female.
19?
19-year-old female. So, word of advice, guys, if you have a young patient, get a female tech to put the tip in. Okay, to avoid any type of lawsuits, get a female tech or a nurse to put that enema tip in. Okay? When they're older, they're like, I've got nothing to hide. You know, they've had 3 babies, 4 babies, like, I don't care. You know, you can tip me. But the younger ones, they're a little bit more conscious about modesty. Okay? And we live in a very litigious world, so be careful. Get yourself a female tech, which I did. I worked in a hospital where I was the only tech that day. Very slow hospital. Okay, it was one of those clinics out in the outskirts of Santa Ana, but very slow, and I was the only tech there. So we had this female patient, 19-year-old, and so I set up my equipment, and I said, I'll be right back. So I went to go grab a nurse from the emergency room, and she did her thing, okay? So I stepped out of the room, she put in the enema tip, she left, and then I came back in, patient was already on their back, and then I went on the phone and called my doctor. I'm ready for you. I'm ready for the fluoroscopic part. So the doctor comes in, and as a technologist, you're the one that's going to be controlling the flow of the contrast. So there is a clamp here that will, it's not on here right now, but there is a clamp here that will clamp the tube off and on. Just a simple slide clamp, okay? Just like the one here that they have with some balloons, just a sliding clamp, okay? For the barium. And so one of the things that you'll be doing is you will be clamping the barium flow off and on. The doctor will say, On, okay, unclamp it. Off, you clamp it. On, unclamp. So you're regulating it, okay? So when we started the procedure, doctor says, okay, barium on. I opened up, and the patient started screaming. She was like, ah! Doctor said, off. We offed it. She goes, is everything okay? She goes, yeah, it just hurts. I said, and we said, well, it's going to be uncomfortable. He goes, are you going to be okay? She says, yeah, I'll be okay. And the doctor says again, on. Ah! She starts screaming some more. And she's like, the doctor's like, what's going on? Is everything okay? She goes, it hurts. And, we've heard patients kind of moan and groan before because it's uncomfortable. But she was in a lot of pain. So we told her to roll up on her side, and the doctor to look to see if there was anything going on underneath, and everything looked fine. He lifted up her cheek. Guess where the tip was? In the what?
Speaking
In
slang.
the wrong spot. It was in the wrong place. So now we were filling up her vagina with barium.
Yeah, exactly. And the female inserted it.
It was a female nurse.
She might
From
not
the
like
emergency
females,
room.
so
She's not a very good nurse.
she didn't like females. So
Okay. So we were done. We looked at we took some shots of her area, and yes, there was a lot of contrast in there. And anyways, she had to get what is that? Douche, a lavage to get rid of the contrast. So again, make sure you know where the tip. So the anus is towards the back. Furthest back. Yeah. Okay.
Hard to explain.
Okay. So it can either be single contrast or it can be double contrast. There's also a study of the rectum, which is called evacuative photography or deficogram. Deficogram.
very literal
I
name.
have a hard time saying it. Deficogram. There's only one hospital in your guys' sites that does it. Anybody know which one it is?
This is the lucky one.
Kaiser. Kaiser Anaheim. Who else is Kaiser Anaheim? Has
Okay.
anybody seen one of these
We're
yet?
safe.
There is a renowned physician that does these. I mean, it's actually a big deal. That's a really big deal. And Kaiser, that one doctor is the only one that does that in entire Southern California. This deficogram. All right. So the lower GI procedure, again, single contrast or double contrast. You're going to be using a little bit thicker barium than what is used for the esophagram or the upper GI or small bowel, so it's a little bit thicker. You're going to use contrast barium as well as room air. There are two ways in how to fill up the bowel. The most common one here is the two-stage, where the barium fills up the left side. So we get the barium that goes up here on the left side. Air is instilled to push the barium to the right. Okay, so you get the barium, and then you're here giving puffs. Doctors say, okay, give it some air, and you're just giving air until they see the contrast moving across the transverse and down to the ascending. You're just pumping. And then the bag is lowered to drain any excess barium. So what they're doing here is they're just simply coating it. They're not filling it up with barium. They're coating the wall with the barium that was initially administered. It gives you better visualization of the internal mucosa. Okay, that's the most common way. The problem with that is that it takes a little bit longer to do, and it's a lot more uncomfortable for the patient because you're pumping exorbitant amounts of air in the bowel. So it does take a little bit longer, okay, but it is more effective. So this is good for demonstrating, what is this here? For neoplasms and polyps, okay? The single stage is just, you just fill up the contrast all the way through. Less time to do and also less radiation, but the visualization is not as good as the two-stage. So you will see this more commonly occurring in your department. I've worked in several hospitals, and this seems to be the most common process, is the two-stage barium enema. Okay. All right. Any questions about this portion of it? All right. So we'll talk about the positions here in a little bit. Let's just talk about now evacuative program, or defecography. It's a functional study of the anus and rectum during the evacuation and rest phases of defecation. The clinical indications for evacuative program defecography is rectal coeles, rectal intussusception, and prolapse of the rectum. And I gave you guys what they mean there. So rectal coele is the bulging of the rectal wall into the vagina. So it may not only be a bulging of the rectum into the vaginal wall, but there may be a fistula or a communication between the rectum and the vagina. That's rectal coele. Rectal intussusception is, again, the telescoping. Prolapse of the rectum is the lining of the rectum falls through the anal canal. So these are indications to do evacuative proctogram. Here's a setup. It's a commode. Okay, they're going to put that right here at the foot end, table standing up, and the patient's going to sit on this commode. The doctor will observe the evacuation of the contrast material as they are defecating. The contrast they're going to use looks. Where have we seen this before? Yeah, when you're building a house.
Except that will cost you know $1,000.
Yeah, so the contrast is extra thick. It's super thick that they need this type of caulking device to get the contrast in. So the patient, it's the same thing as setting up for a barium enema. They're going to lay on their side. They're going to connect the tube inside the rectum, and they're going to push this contrast through, and then they'll sit them up, table up, and then they'll sit on the commode. Okay, but insertion or instilling of the contrast is the same concept, yeah.
So you say that the patient is defecating, meaning that there is no fasting for like 8 hours or after midnight. He needs
No,
or she.
they still need to be clean.
Oh, so it's not really defecation; it's just barium coming out, right?
Sure. Yeah.
Okay,
yeah.
so it's not
the process of defecation.
Okay.
Of evacuation, yes. So the question is, so there's no fasting.
Yeah.
Yes, there's still fasting involved because we want to make sure that the bowels are clean. Any type of residual material in there can be misconstrued or misidentified as pathology or some kind of neoplastic process. Okay, so this is a defecogram. Patient is sitting, so they're sitting. Here's the sacrum. Here's the legs, so they're sitting down. And what the doctor's doing here is they're measuring the angle between the rectum and the sigmoid area during relaxation and also when they're bearing down. And if there's any deviation from what's normal in that angle, and that's what they're trying to look for. So anal rectal angle is measured and compared between rest and evacuation. And then also do it post-evac. That means after they've did their very best to eliminate the contents, then they'll do a post-evac radiograph. Special supplies for colostomy. So sometimes you may have an individual that needs a colon study using the contrast. So instead of going into the rectum, we'll just go through their stoma, through their abdomen, and fill up the contrast that way. Same equipment. But again, instead of going through the rectum, we're just going to go through the stomal opening. And we'll put this little patch that acts as a valve to cover up the stoma. And then we'll insert the enema tip through there. Okay. Summary of safety concerns, review chart. Never force the enema tip. Height of the enema bag should be no higher than 24 inches, and verify water temperature. We'll talk about escort patient into the restroom here later on. This is a post-procedural type of event. All right, so I'm going to skip through this. You guys can review that on your own. And we'll begin talking about the barium enema procedure. You guys okay? Do you guys want to go on break or keep on going? Break or keep on
Let's
going?
keep going. We only have 10, 20 slides or so.
Oh, really? Oh, okay.
We're almost there.
All right. So the basic views then. So again, you tip the patient. Okay? You get them on their back. You call the doctor. The doctor comes in and starts doing his or her fluoroscopic part of it. Okay? And you'll be there assisting, turning on the barium off and on. Now, for those who, only 2 of you guys have seen barium enemas? Okay, so let me ask you 2 students. Was the doctor in the room when they were performing this? No? Yes. Okay? So, there are some procedural rooms now where they control everything from the outside in the control room, including the flow of contrast. So the doctor's doing everything from the outside of the room. Okay? But there's also where the doctor's out of the room, the tech is still in the room controlling the contrast. That's what happened to you, right?
Yeah.
Was the doctor out of the room?
Yeah.
And you were controlling the contrast. Okay. And there's some places where the doctor and you are inside of the room. So that's the fluoro part of it. And once they're done with the fluoro part of it, then these are the overheads that you will perform after the fluoroscopic portion of it. These are your overheads. So after the fluoro is done, this is what you're going to be doing. Again, there's going to be some variations because some of the hospitals, they get everything they need during the fluoroscopic procedure and they're done. Some places, they do the fluoroscopic part and you still need to do overheads. For those who do overheads, it may be limited to maybe 3 or 4 views. Whereas if they want a full study, then you have to do 1, 2, 3, 4, 5, 6, 7, anywhere between 9, 10, 11 views. Now imagine having to do that with this patient have their tip up their butt and their belly still full of barium. You got to be and accurate. Okay, so you're in a time frame. So you got to do all these shots very quickly and very accurately because the patient's going to be uncomfortable. Ms. Jones, we're going to do our very best to get through this procedure as quickly as possible. Okay? You need to let them know that. We're going to get through this as quickly as possible. All right? So here are the views. All right. AP and PA. It's your KEB, guys. You already know how to do this, right? Center where? At the crest and mid-sagittal plane. There we go. We're done. Okay? Well, why do we do AP versus PA?
To spread the...
Okay, PA, we spread it around, but we also want to see the anatomy. Okay, remember, your ascending, descending is posterior, your transverse is anterior. So AP and PA, although they may be same positions, we're looking at different things because where is it that the barium settles and where is it that the air goes? So relatively the same positions, but the position or the where the barium and air goes are going to be giving you 2 different pictures. Okay, so remember this. Again, this is a single contrast, so you're not really seeing the effects of